Moving ahead with the program, our next topic is anesthetic management of uncontrolled diabetes mellitus patient posted for chest wall debridement by Dr. Meenakshi Sundaram sir. And chairpersons for these are Dr. Balavenkat sir, Dr. Yashwant Bedesgavkar sir, and Dr. Kavita Jadhav madam. We request all chairpersons to head to the dais. Our escort committee members will escort all the chairpersons and faculty to the dais. As we all know about the Dr. Balavenkat sir, our next chairperson is Dr. Yashwant Bedesgavkar sir. Sir is consultant anesthesiologist at Sangli and Miraj, and he was a past clinical secretary and president for ISA Sangli Miraj branch and GC member for ISA Maharashtra state chapter. Dr. Kavita Jadhav madam is practicing anesthesiologist at Tasgaon.
When you attend a morning session, we need a lot of movements happening in the facial muscles, and the mouth has to open and the lung has to generate a noise, laughter, and for that we have Dr. Meenakshi Sundaram here.
Oh my goodness.
So such a pleasure to have you, sir, where he makes every topic look simple. And humor brings down the heart rate and the blood pressure. And if you need to, he wants to make sure that every anesthetist lives for 100 years, like hip fractures, and all those who have. So I think, thank you so much, Dr. Meenakshi sir, for innovating new things in your talk and also presenting it in your own style. So I think henceforth we will have Meenakshi Sundaram style of presentation.
Thank you, Chairperson. See, I'm really honored because my session is chaired by a WFSA secretary. So it should go on record because I will never get a chance again. I will not visit any foreign country to speak from the podium. And India has to wait for another 100 years to see a WFSA secretary from India. So I have achieved both, and I thank extremely the Sangli Miraj branch because routinely from Tamil Nadu, 2 people are visiting Maharashtra for delivering lectures. Both of us are in the same stage. This is the first time we are on the stage. So conference is nothing but an education and entertainment. So for education, Balavenkat is here. For entertainment, I am here. So anyway, I will not change my style. I will not be so emotional like Dr. Balavenkat, because he himself mentioned it is my own style, because I want to live happily. I will not do any research, because research and all these people will waste time and they will do. We just read. Within 2 minutes you read, apply, acquire, apply, matter is over. So I will not waste my time. I enjoy, because when they are wasting the time in research, I will be watching the Bollywood movies to learn Hindi. That is my idea. But the chairperson has to delete this time, because it is not concerned with my lecture. Okay, see, now this is, we are honored by the presence of ISA President-elect Dr. Balavenkat, ISA Academic Committee Chairman Dr. Bhimeshwar, GC members Dr. Manisha, again Dr. Pankaj, Dr. Ashok Deshpande sir is also here with Dr. Anita Nehete, then your Vikas Karne, your Secretary Rajesh Takatpalli. Why I am mentioning all these names? I remember all those things. So that is my idea, because I am frequenting Maharashtra. That is the reason why I could say. But today, when I was a former DME and a Vice President of ISA National, I have one more credit to me. I am accredited Maharashtra Medical Council speaker. This is my accreditation number. So I am accredited speaker by the Maharashtra, that I want to say. So I thank the team, Sangli Miraj, because it is the second time visiting Sangli Miraj, and the heroine of the day, Dr. Rupali Gargal, who has invited me for this lecture, backed by one-day-old birthday baby, Dr. Vasudha Jadhav. So I thank every one of you. Usually life starts as a child, then the child will grow, Buddha banega. Here the lecture started with the elderly, suddenly came to pediatric. Now I am in the middle, 40-year-old. And I am wondering why these people have selected that age 40 year and do a curse for male diabetic, 40-year-old male diabetic. What is the big difference? I don't know. But anyway, they have mentioned, and it's a chest wall wound. I don't know whether it is an anterior chest wall or a posterior chest wall. But I asked Manisha madam whether it is a PG symposium or not. Because I am seeing mostly more than 50 years old people here. except ladies, okay? So, all are looking more than 50 years old. I was wondering whether PGs are present here or not, because I want to address, I have prepared it in a question answer format session so that they can appear well in the examination. Anyway, now I am addressing 50-year-old postgraduates, okay, about a 40-year-old man. So, when a 40-year-old man, uncontrolled diabetes mellitus, he is having a multi-organ dysfunction. Everyone knows that. Because mainly we are concentrating on heart and kidney and delayed gastric emptying. I want to emphasize here, because they have to be treated as a full stomach, and reduced joint mobility will be there in diabetes mellitus. So, anti-diabetic agents, I will not go in detail. Why I am projecting this slide? Variety of drugs are coming to control diabetes mellitus. Entire problem lies on the shoulders of anesthesiologists, like antiplatelet agents, 40 to 50 antiplatelet agents, 40 to 50 low molecular weight heparin. For everything, we have to read the time, onset of action, duration of action, then we have to modify anesthesiology plan accordingly. They will not change the drug. Okay? So, it is a burden on our shoulders. So, you read so many insulins. If I start talking about insulin, it will take 2 days. So, you read, the idea being, just study which insulin he is taking, how long it is going to act, plan your method. Then why we are bothered about this diabetes mellitus? Glucose itself produces some toxins. It promotes non-enzymatic glycosylation reactions. So, it increases cellular swelling, cell death occurs. That is the reason why hyperglycemia disrupts autoregulation. So, the wound healing is delayed. That is the first take-home message. Hyperglycemia should not be there. Even Dr. Balavenkat, when he answered a public through media, he said, never allow your sugar to go above 100. It is very difficult for the anesthesiologist. Whenever he sees a patient, his sugar level goes up, his heart level goes up. Anyway, if you want to live for 100 years, don't allow your sugar to exceed 100, okay? So, the glucotoxicity, whenever the hemoglobin HbA1c is more than 8, it is a cause for concern. We have to look for microalbuminemia also. And just they said it is 40-year-old man, it looks simple. But uncontrolled diabetes mellitus, you have to check the physiological aging. If the patient is suffering from insulin-dependent diabetes mellitus type 1, then you have to multiply the age by 1.75 if it is uncontrolled. If it is type 2, what they have given me, 40 years means he should be treated as 60. Okay? And Dr. Balavenkat has put a cutoff. From the age of 40, your cells will start slowing down. So that 40, I am there in the age of 40 as far as the patient is concerned, but it should be treated as 60. Okay? So, the autonomic, you have to check for autonomic neuropathy. The examiner will ask the postgraduate, what are all the problem with autonomic neuropathy? So, these are all the symptoms of autonomic neuropathy. Mainly, the lack of pulse rate change, postural hypotension, nocturnal diarrhea. They all indicate the patient is suffering from autonomic neuropathy. If the patient is suffering from autonomic neuropathy, there will be impaired respiratory responses to hypoxia and hypercarbia. And worse still, if the patient is having autonomic neuropathy, they are prone for intraoperative hypotension. You have to be very careful with the central neuraxis block. And if you want to intubate the trachea, the pressure responses will be more. And worse, hypoglycemia, they will be unaware. That is the reason why we say even the myocardial infarction will be a silent myocardial infarction if the patient is suffering from autonomic neuropathy. Worst thing in autonomic neuropathy, atropine may produce bradycardia and beta blocker may produce tachycardia. That means you cannot say what will happen in autonomic neuropathy. Drugs will not act on expected lines. So you be careful if the patient is suffering from autonomic neuropathy. So, the vagal control is absolutely lost, and as I said earlier, there will be altered respiratory reflexes and impaired ventilatory responses. Then sudden arrest is common. In uncontrolled diabetes mellitus, sudden arrest is common. The sudden arrest may be due to your anesthetic agents, or the patient may be suffering from pneumonia, or the sedatives which we use. So, you have to check for autonomic neuropathy. and you have to check for the differences between maximum and minimal heart rate change during inspiration. Now I want to tell you the surgery and the general anesthesia, what it does to the patient. There is a relative state of reduced insulin secretion in surgery and anesthesia. That is the reason why hyperglycemia is possible during the perioperative period. And the release of hormones, glucocorticoids, growth hormone, everything will increase sugar level. And because of increased sugar level, dehydration occurs. Impaired wound healing occurs. The central nervous system injury is more with hyperglycemia. And nutshell, surgery and anesthesia are catabolic phenomena, but we require a anabolic phenomena. That is the reason why we want to reduce the stress. So insulin is anabolic hormone, we want anabolic effects. So when a diabetic patient is posted for surgery, think whether it is a major surgery or minor surgery. For diabetes, I want to change the terminology. If the patient could take orally within 24 hours, we can consider it minor. Idea being, we need not change, we need not break our head in changing the insulin regimen. If the patient cannot resume food, oral intake within 24 hours, it should be considered as a major surgery. Here it is a chest wall wound debridement, so I take it as a minor surgery only. So what is the anesthetic management? Immediately coming to the point. See, I want to tell so much. Blood glucose level is not important. If the blood glucose level is 400, don't be annoyed. First you assess what is the end organ damage, because that decides the mode of anesthesia. So end organ damage is important. So the WHO says, World Health Organization, you target 108 to 180, 108 to 180, but allowable is 72 to 216. These are all the research terminologies. So the glucose control, how to control glucose, it decided by type of operation. It is very simple, chest wall wound debridement. Pregnancy is a problem. Now it is a 40-year-old male, he will never become pregnant. So that is also an advantage for us. So the predicted CNS insult is common. Then bias of the primary care physician. I may like to have a blood sugar of 160, somebody may like to have a blood sugar level of 230. So it is up to them. Then the type of diabetes, insulin dependent diabetes, you have to be very careful, but this is type 2 diabetes. So when to change to insulin, all type 1 go for insulin, type 2 diabetic, if it is not controlled by oral hypoglycemics, go for that. Decide on case to case basis, don't ask me what is the blood glucose level with which you will proceed. Don't know, I will not answer that question, okay, because it is only the changing terminology. So the preoperative evaluation to assess asymptomatic coronary artery heart disease, it is important. So ask for early satiety, erectile dysfunction, numbness in the extremities, postprandial vomiting. And in the preoperative evaluation, I want to stress, please document the pulse, because sometimes because of vasculitis, left radial may not be palpable. So during surgery, if you suddenly check, you may diagnose cardiac arrest, when it may be due to vasculitis. Usually in vascular surgery, they will mark which pulse is palpable. Sometimes it will be only superficial temporal. So you document pulses, document skin breakdown, even for medico-legal purposes. Sensory examination. If there is a central neuraxis block, you have to check for the sensory examination. Then demonstrate the orthostatic vital signs. Then your routine testing, ECG, blood urea sugar, to assess the end organ damage. Assess concurrent medications, then assess autonomic neuropathy. Pre-medication, you can go for any pre-medication. Beta blockers are acceptable, atorvastatin is acceptable, and because of Dr. Balavengat's lecture, aspirin is also acceptable. But even before that, when I was a postgraduate, we will not ask whether the patient is taking aspirin or not. We will give spinal. And sometimes the theatre technician will say, if you say aspirin and clopidogrel you are taking, anesthetist will not assess. So you give me 100 rupees, I will tell you a clue. Then he will say, sir, I am not taking clopidogrel aspirin, sir. Till morning you would have taken. But we have given spinal also. Nothing had happened. So that means ignorance is bliss. These people have found out very late that the platelets are acting 40%. But we have diagnosed it some 30 years back. Right and left we were giving a central neuraxis block, no epidural hematoma, no spinal cord insult. So what I want to convey, sometimes Ignorance at a later date may come as a evidence-based medicine. Okay. So the insulin, you have to decide on case-to-case basis. But for this patient, I don't want to break my head in tackling. This is for completion's sake I am saying this insulin dosage. There are so many regimens. No insulin, no glucose regimen, tight control regimen, non-tight control regimen, so many things. This is just to make the postgraduates to torture and read. We are reading so many things. At last, what you are going to do? You are going to acquire knowledge from academicians, okay? And you will apply whatever you are practicing. You are not going to change. The same thing is going to happen because it is your place. So the no insulin, no glucose regimen, avoid dextrose infusions. Check blood glucose every 2 hours. Whether you are a diabetologist or not. Even the diabetologist, what he does, every time he will check for sugar, he will tell the insulin. So whenever you are in doubt, you check insulin, then decide, check your glucose, then decide whether insulin is to be given or not. Okay, so that is very simple. Don't worry about diabetes mellitus. So the non-tight control regimen, the patients will be starving overnight, then morning surgery will be planned, then 125 ml per hour per 70 kg. These are all research documentation. But what I used to do practically, we have to apply. So whatever fluid you use, check blood sugar, use insulin or give dextrose. This is very simple. If the blood sugar is less than 80, give dextrose. If the blood sugar is more than 200, give insulin. So the target is 160 or 140, that is my aim. So it is very easy to practice. Only thing, you have to again and again test blood sugar. Now it is very easy. The one-stop glucometers are available, so we can perform the thing. Then the sliding scale, this is also, it is very easy to remember. This side, right side, you write 2, 4, 6, 8, 10. Okay, 2, 4, 6, 8, 10. This side, you do 150, 200, 250, 300. Learn. This is for examination purposes. Practice as you like. Okay. So the tight control, if the patient is going for a coronary surgery, then definitely you have to go for a tight control because it gives some result. But in the wound debridement, we need not go for the tight control regimen. So that idea of tight control regimen is to keep the blood sugar between 80 to 120. Okay. Accordingly, we will transfuse glucose or we will give insulin drip. So insulin drip can be even given by a piggyback infusion. Then we have insulin, potassium and a glucose regimen. If it is afternoon list, but this cannot be afternoon list, it is a elective surgery only, so we can plan it in the early morning. Then the regional anesthesia. So once the regional anesthesia comes, in diabetic patients, the regional anesthesia requirements are very less. And combining local anesthetic with epinephrine, there is a greater insult. Vasospasm is more common with these diabetics, so we have to be very careful. And you have to be very careful about hemodynamic compromise if you are going for a central neuraxis block. So what are the regional techniques that can be practiced? In GA, I think this can be done with the simple IV analgesia. If the examiner asks, you say general anesthesia. These are all for postgraduates. Never say, I will go for segmental thoracic epidural or segmental thoracic spinal. Because if suppose the examiner is interested in segmental spinal, then you will be getting caught in orals. So never tell that. Say ketamine, then he will ask, oh, ketamine will increase blood sugar. Yes sir, yes sir. Then you say yes sir, yes sir. But it is very easily you can practice. So if at all you want to give segmental spinal, what I will do? I will not take that headache. I will refer the case to Dr. Naresh Paliwal. Let him look after why you break your head. So, but there is a possibility you can go for a segmental spinal thoracic. So, the T5 to T8 prick is very, very difficult. So, you go between T2 to T5 or T9 to T12. That space will be very easy. You can practice. This is for completion sake. Segmental spinal, segmental epidural. Then you can go for an intercostal nerve block. So, there are so many ultrasound guided nerve blocks available. But I am not here to say that because it is very difficult to practice here. But whenever you practice a central neuraxis block, please look for hypotension. So if it is an emergency surgery, try as far as possible to correct the fluid and electrolyte balance. even if it is an emergency, because even if it is an emergency, you can wait for 2 to 4 hours. That is sufficient to maintain the hemodynamic balance. So when the serum glucose, usually in diabetic ketoacidosis, we use insulin and dextrose. Insulin is given till the blood sugar level reaches 250. Once the blood sugar level reaches 250 milligram, we have to add dextrose and insulin. You have to continue insulin until the acidosis resolves. But if this case is posted with diabetic ketoacidosis, simultaneously you have to anesthetize and simultaneously you have to treat, because this wound infection itself may be a cause for precipitation of diabetic ketoacidosis. So the IV fluid, sometimes the patient may require 5 liters, that is 10 units of IV fluid. At that time, we have to be very careful with pseudo-hyponatremia. That is, it will be like hyponatremia, but pseudo-hyponatremia, like these dolls in the showroom, looking like MEENAKSHI, okay? So you have to be very careful in calculating the fluid deficit and correct it. In the acidosis treatment, I want to concentrate on only one thing. Please never venture with sodium bicarbonate in diabetic ketoacidosis. Sodium bicarbonate is indicated only if the blood sugar is reaching, pH is reaching 7.1, because at a pH of 7, myocardial failure occurs, death occurs. So if it reaches 7.1, you can venture with sodium bicarbonate. That too, calculated dose, only 50% you have to give, because the sodium bicarbonate produces paradoxical CSF acidosis, meaning if the patient blood is at acidotic, it stimulates the respiratory center and it increases the breathing to produce alkalosis. So if you neutralize the blood pH into a normal pH, the CSF, it cannot cross the blood-brain barrier. So CSF thinks still the patient is acidotic. Again the blood respiratory level goes up. It is very easy to treat acidosis by giving a sodium bicarbonate, but it is very difficult to treat alkalosis because there is no treatment. Ammonium chloride is indicated. I don't know where it is available. So never venture with the sodium bicarbonate at the first step. Then electrolyte disturbance you have to correct. In the postoperative period, again the same thing. In the postoperative period also, because of the stress, increased blood glucose level will be there. Stimulation of lipolysis will be there. Everything increases blood sugar level in the postoperative period. So in the postoperative period, the stress response is to be cut down to a minimum. So pain relief is mandatory. So give a good pain relief for these patients. So in the postoperative care, you maintain them in high dependency unit because it is uncontrolled diabetes mellitus. Continue infusions till the blood sugar reaches 150. Then the total insulin requirement calculate, and 50% of the insulin can be given as a night dose, remaining in the morning divided doses. So you can select a long-acting insulin during the bedtime. Then the $1 million question, the postgraduates would like to know, sir, at last what answers we have to give in the examination? I have enumerated. Say first ketamine, then you go for general anesthesia, then go for regional anesthesia. And if you are going to talk about any particular nerve block, before answering, please rehearse whether you know the course of the nerve, whether you know the nerve supply of that, what are the muscles it supplies, then you come out. Because you may not be knowing. If I am coming as an examiner for you, I will not ask anything about ultrasound guided nerve block. But imagine if that central man comes and if you say some pink block, this block, that block, you are gone. Completely gone. At that time, it is very difficult for you to come out of the examination hall, right? Whether you pass or fail at that area, you will be failed. So now I will tell you regional anesthesia or general anesthesia. Now, this lady has just delivered a baby, but she is looking after WhatsApp. She is not interested in the general atmosphere. She is concentrating on the regional atmosphere. But if I ask that lady may say, sir, I am interested in this. Nurse will take care of the baby. So, she is interested in regional anesthesia. But now, this man not bothered about regional beauties. He is concentrating on a general atmosphere. That means he is interested in general anesthesia. So I cannot say who is right, who is wrong. Whether it is Sangli, it may be regional. Whether it is Tanjavur, it may be general. So I will not make a comment. I will be tight-lipped. So I cannot say which is best because there is no safe anesthesia technique. Anesthesiology is just like swimming. Whether it is a butterfly stroke or a free stroke or a breast stroke, whatever technique you may practice. But the winner will be who is reaching the shore safely, right? He has to reach the shore. So whatever may be the anesthesia technique you prefer, you have to win in that. So there should be a safe anesthesiologist, but there is no safe anesthetic technique as it is called. So I want to say anesthesiology is the only field which goes against nature. We are working against nature. We are making a conscious person into unconsciousness. Again, bringing him back. Everybody wants to protect the protective reflexes, but we are the one who block the protective reflexes to keep the endotracheal tube in the trachea. So we are always against nature. So there is no safe anesthesia drug or a safe anesthetic technique. If you want to be a winner, you be a safe anesthesiologist. So I thank you, the entire Sangli Miraj branch. I have visited most of the places in Maharashtra. So it is a second home for me. And I meet Dr. Balavengat more frequently in Maharashtra than in Tamil Nadu. Because I am also coming here, he is also coming here. We meet only at the airport. In my area, I am busy. In his area, he is busy. So thank Sangli Miraj for getting a reunion of two Tamil Nadu people. Thank you.
Thank you so much, sir, for this wonderful session. Now we will take the question answers in tea break. And now chairpersons will felicitate Dr. Meenakshi Sundaram, sir.
Just one question, because having regional anesthesia very close to the heart, I would, if I am an examiner, I will not ask the course of the nerve, but if the answer is regional anesthesia, I will give him a pass. Because the amount of stress response between GA versus regional in a chest form deformity to do a case with site-specific analgesia, we have PEC 1, PEC 2, we have the serratus anterior plane block and erector spinae block, C1 do 1 block, EC to give this interfacial plane blocks, gives excellent results. I would not go for thoracic spinal because again it's not very safe even in the best of hands. So the answer is regional, and knowing, I'm just seeing Rupali's face because the time is going on, so I will stop here. And we thank Dr. Meenakshi Sundaram for presenting his thoughts in a very unique way, in a way that is remembered, in a way that's very practical. Thank you so much, sir. Thank you.
Dr. Ruta will escort and Dr. Mohan Patil, sir, will felicitate the chairpersons at felicitation venue.